My slide is visible and I am audible.
Yeah,
The slide is visible, sir.
You have not shared the screen yet.
Okay, okay, something very
No, sir, you are not shared. You have to share, then it will become.
okay. Is that okay?
Yes, yes, sir.
No, again something wrong. Now I'm okay. So I'm audible also?
Yes, sir.
You are
Right.
audible.
Yes, sir.
Okay. So friends, good evening. I first of all take this opportunity to welcome all the office bearers of Indian Orthopaedic Association and all the faculty members. Friends, it's a great delight when you organize a webinar and the head of the family, the president, Dr. Atul Srivastava, is present along with President-elect Dr. Ram Chaddha and our Secretary General, not Secretary, but Secretary General, Dr. Naveen Thakkar, and we have association of our very own President of Indian Orthopaedic Rheumatology Association, Dr. Shantanu Lahkar. Friends, the topic we are going to discuss is in this first webinar is biologics in orthopedic rheumatology. And I will now request Dr. Atul Srivastava, President IOA, to give his inaugural address.
Namaskar and good evening to all. And Naveen, can you mute yourself? Naveen, can you mute yourself? Thank you. So I wish you all a very happy, safe, prosperous, successful, and for the IOA, a harmonious 2023. It is really heartening to see that the subcommittee of the Indian Orthopaedic Association on Rheumatology is organizing this webinar today, and it says the first webinar that itself proves that it is going to be continuing with many more webinars under, of course, the patronage of our own Dr. S.S. Jha sir, who has put in so much of effort along with his committee members, Dr. Ranjeet Singh, Dr. Chinmoy, and Dr. Sharat Agarwal. A few days back, we had a webinar on Introduction to Orthobiologics on the 7th, and here we are on the 12th on being a bit more specific. So this is Orthobiologics in rheumatology. In very interesting topics, eminent speakers, and I'm sure all of us are going to gain a lot at the end of the webinar. Thank you, sir. Thank you for the invite. Thank you.
Thank you very much for all the encouragement that we have been receiving from all over Indian Orthopaedic Association, beginning from previous so many years. Now is the turn of our President-elect, Dr. Ram Chaddha, to say his inaugural words.
Good evening, everybody. Professor S.S. Jha, thank you very much for the invitation. I welcome each one of you attending this very interesting first webinar by the Indian Orthopaedic Rheumatology Association. We have the president of the IOA, our own Dr. Atul Srivastava, who said, strong bone, stronger nation. And we have our Secretary General, Dr. Naveen Thakkar, who represents the three of us who are a part and parcel of the IOA and have been with you and would be for the next year. We also welcome the president of the IORA, Dr. Shantanu Lahkar, with whom I have a very old association right from the days when we were spine surgeons together in the past. And it's been a pleasure to have you, sir. We have eminent speakers. We have Dr. Ranjeet Singh, we have Dr. S.S. Amarnath, we have Dr. Chinmoy Das, we have Dr. Sharad Agrawal, we have Dr. Dhansekhra, Dr. Jayaraman, each one of them, along with Professor Ravi Gupta, who's going to enlighten us on something that we know very little about. Biologics is something where either we refer the patient to the rheumatologist or we say कि नहीं नहीं ये इससे कुछ फर्क नहीं पड़ता. But gentlemen, and I have been actually educated by Dr. S.S. Jha that this is something which is an integral part of our contribution to rheumatology, and we need to know more about it and use it in our practice on a regular basis. Besides just writing one drug, we should know what is to be used, when it is to be used, and how efficacious it is. Hence, this particular meeting today to educate ourselves with our colleagues who are actually using it and are using it regularly. Thank you very much, each one of you, the attendees and the faculty, for being here to tell us something that we know very little about, but want to know more. Thank you all. Welcome to this excellent webinar. God bless you.
Thank you, Dr. Ram. And now it is the turn of beaming Dr. Naveen, who has always been a very good promoter of whatever we have been doing and supports this Indian Orthopaedic Rheumatology Association. Your opening remarks, Naveen.
Thank you, sir. Thank you, sir, for the invitation and your remarks for us. And this committee is working very hard since last 2 years, we are seeing. And all the webinars are very, very informative and very much we are getting feedbacks. Learning is something new. Ultimately, it is helping our patients. So I will not waste much time, but let the academics flow so that we can get more and more knowledge out of all the faculty, and we are thankful to all the faculty on behalf of the Indian Orthopaedic Association, and we welcome all the delegates. And these are getting recorded in the IOTV, and you will be able to see everything on IO website now, all the education material. Everything will be available on our IOTV and IO website. So please visit IO website and get all the webinars and information, previous webinars, and continuous knowledge is going through all the videos, surgical procedures and everything. Thank you very much, sir. Thank you.
Thank you, Naveen. And now it is the turn of Guru of Gurus, Dr. Shantanu Lahkar, who is incidentally the president of Indian Orthopaedic Association also. Indian Orthopaedic Rheumatology Association.
Good evening to all, and best wishes for our new year 2023. Respected President IOA Dr. Uttul Srivastava sir, President-elect Dr. Ram Chaddha, Secretary General our Dr. Naveen THAKKAR, who is always an inspiration for all of us. Our most respected, our teacher, Dr. S.S. Jha sir, and Dr. Manish Khanna in his absence, all the faculty members and participants. As already mentioned, keeping in mind of IOA President theme, 2023 Strong Bones and Strong Nation, today we are going to start our first webinar, Biologics in Orthopedic Rheumatology. And I convey my best wishes for the beginning of our journey. Thank you. Thank you, sir.
Thank you, Shantanu. Well, friends,
Very good evening.
yes, hello. Am I audible?
Sir.
Yes. So, friends, today's topic, biologic in orthopedic rheumatology. This subject has been kept as the topic of first webinar to allay the fears of our orthopedic brothers that we as orthopedic surgeons should not write or are not permitted to write biologics. This is a wrong notion. So we have every right to prescribe, but then we should understand the modalities before prescribing it. Well, whatever treatment is feasible for rheumatic diseases, they are basically called as disease-modifying anti-rheumatic drugs. And these drugs can be classified into conventional synthetic DMARDs, targeted synthetic DMARDs, and biologic DMARDs. So biologics are also DMARDs. Normally what we understand that no, only sulfasalazine, methotrexate, hydroxychloroquine, they are DMARDs. No, they are conventional synthetic ones, including leflunomide, and the small molecules like tofacitinib, so much in use now, baricitinib, they are targeted synthetic. And the biologics are also known as BDMARD, out of which we have got anti-TNF and so many others that we are going to discuss. Now, if the originator has developed a biological DMARD, this is known as BODMARD, and biosimilars are known as biosimilar DMARD. Similarly, talking about targeted synthetic, the small molecules, which are also known as JAK inhibitors, you can see the figure of two heads in one statue. This is god Janus, and this god Janus has two faces. One looks into the past and one looks into the future. Now, chemically, this is more related to traditional methotrexate than to biological DMARD. Friends, it was in an attempt to develop a oral biologic that this development took place. So small molecule are oral drugs which are known as targeted synthetic DMARDs. They work like biologics, but structurally or chemically they are more related to traditional methotrexate. Now, onset of response occurs within 2 weeks. Efficacy is maintained up to 5 years. It targets multiple cytokines and it inhibits intracellular signaling pathways. I must tell you here itself that this is the only targeted synthetic DMARD which works inside the cell. All the biologics that we are going to discuss, they work in extracellular space. So here it transmits signal from surface receptor to the nucleus, whereas all the biologics will only work on the surface receptors. Without going into more details, now it is the turn of the expert of IOA Rheumatology Subcommittee 2023 and Professor Ranjeet Singh, who is professor in the Department of Orthopedics in Patna Medical College, will speak about biologics, a preview. Dr. Ranjeet.
Thank you, sir.
I stop sharing and you load your presentation.
Oh, so, may I start, sir?
Yes,
With your permission, of course.
sure.
So, I'm giving an introductory, a bit of about biologics. So, this is about me, nothing very special. So, medicine has come a long way in very short time. New and interesting drugs make a big difference in our everyday lives. And the most exciting of these new drugs are the biologics. These drugs offer better treatment options. They are targeted, personalized, and patients are, they are good for the patient like never before. But what are these biologics? They are manufactured in, extracted from, or semi-synthesized from biological sources or living sources like human, animals, plants, fungi, microbials, etc. There are a wide range of products, right from vaccines, blood to recombinant therapeutic proteins and living medicines used in cell therapy. But what are they? To define them, biologics can be composed of sugars, proteins, or nucleic acids, or combination of these substances, or maybe a living entity such as cells and tissues. Some regular agencies use the term biological medicinal products from them to differentiate them from blood and vaccine, etc. These medications are given with needle either injected under skin or infused in a vein. There are four major categories of biologicals: TNF-alpha inhibitors, interleukin inhibitors, T-cell inhibitors like abatacept, B-cell inhibitors like rituximab, etc. So many are formed by the recombinant DNA. What is this recombinant DNA? Formed artificially by combining constituents from different organisms, also sometimes referred to as chimera. This rDNA generally means taking a part of one DNA and combining it with another strand of DNA, thus the name recombinant. And this way, scientists are able to create a new strand of DNA. This is the way they, in laboratory, this recombinant DNA is formed. Probably it won't much interest to orthopedic surgeon, but just for the sake of knowing a little bit. So what this rDNA does, so many substances are produced by this recombinant DNA, substances that are identical to body's own key signaling proteins like erythropoietin, growth hormones, biosynthetic human insulin, or its analog or teriparatide. Then drug of our interest, monoclonal antibodies. These are similar to the antibodies that the human immune system uses to fight bacteria and viruses, but they are custom made. And then finally, receptor constructs. Here, the naturally occurring receptors are joined with the immunoglobulin and they intercept the TNF-alpha and don't let them join with the TNF receptor. So that's why preventing this cascade of events, inflammatory events. Then there are two types of antibodies, polyclonal and monoclonal. Polyclonal antibodies are preparations from immunized animals and it consists of complex mixture of different antibodies produced by many different B-cell clones, while monoclonal antibody are homogeneous antibody preparations produced in laboratory, consist of a single type of antigen binding site produced by a single beta cell clone. There are different types of monoclonal antibodies depending upon what is the percentage of human or animal source in it. This 100% mouse is mouse mAb, 33%, one-third is chimeric mAb, 5 to 10% humanized mAb, and if it is 100%, then it's fully human. This has got a minimal immunogenicity. It has got a possibility of multiple treatments, and serum half-life is more. The problem with these mAbs are the nomenclature. They're difficult to pronounce, but how the name is given. Take an example. The common mAb stem placed as an suffix denotes a monoclonal antibody. Typically, a monoclonal antibody name has 4 segments and 5 syllables. Segment 1 is a prefix and is random under the control of drug dealer. Segment 2 denote the target or disease. A vowel may be added for the add of pronunciation, like, and that is B for here, B is for bacteria, F for fungi, and T for tumor. Segment 3 indicates the source of antibody, U for human, A for rat, and XI for chimeric. And finally, the suffix mAb to denote this is monoclonal antibody. And now let us try it on dinutuximab. Dinu is the distinctive prefix. TU is T for tumor, and U is added for ease of pronunciation. XI means the antibody is chimeric, and MAB denote the class of drug monoclonal antibody, and that is the name is dinutuximab. Then other thing that is very important is fusion protein that is produced by, again, rDNA. Fusion proteins are chimeric proteins and created through the joining of two or more genes that originally coded for separate proteins. A fusion protein combines the attributes of more than one protein in a way that enhances its ability to treat disease. Etanercept is a fusion protein produced by rDNA. Then there are various names in market for biologic. They say this is original, this is biosimilar. What are they? Originator biologic or reference product is the initial biological product submitted to the FDA for approval and not related to any other biological product. This is the product a biosimilar is compared with, also used for determining interchangeability of biological products. While biosimilars are products shown to be highly similar to the reference product, no clinically meaningful difference between the biological product, along with no difference in safety, purity, and potency. While the interchangeable product is a biological product that has been approved for substitution for another biological product without the intervention of the prescriber of the original products. They call it sometimes fingerprint biologic. It's just like you look at this Pinot Noir. This is a grape wine produced by this grape produced in France and California. A wine produced by these two same grape cultivated at two places. The wine produced is almost similar but not identical. That is the story for biosimilar and original. Why is there growing interest in biosimilars? It is estimated that by 2022, 1 trillion on medicine will be spent in all these countries. 17% of drug spend is allocated to biologics. Biologic sales are growing at the rate of 14%, while normal other drugs are at 4%. Biologics represent approximately 1% of claims. Patent expiry could offer opportunities for drug spend savings because the prices are to come down. So what are the expectation of a clinician, as our president told? It should efficacy. It should be proved in a planned clinical trial. In clinic efficacy, and also it should be interchangeable. Safety, similar adverse events profile, and low immunogenicity as the original product. And of course, finally, affordability for the patients. Conclusion: biologics shall become an important part of future healthcare landscape. With patent expiration of innovator products, the biosimilars will increasingly become available. Physicians must consider the following points for proper prescription and safety of the patients: purity, efficacy, safety, immunogenicity, and of course, very important, cost of therapy. Thank you, sir. And I hand over to
Thank you
Chairman.
very much. You have to stop sharing. Right. So, Dr. Ranjeet, I must congratulate you for you have with lot of clarity explained even why and how the nomenclature has to be like that. So each word of the nomenclature you have clarified.
Very nice. Professor
Yes, you have joined, and I know you are in a running train.
Yeah. So
Right.
there are issues. Yeah.
So,
Evening to all.
so Dr. Ranjeet, and you have also talked about biologics and biosimilars, and you have very aptly discussed it with the grape product produced at two different places, and one is a biologic and the other will behave like a biosimilar. So you have discussed about all the cytokine targeted therapies, which are TNF alpha inhibitors, alpha inhibitor biosimilars, then IL-1 inhibitor, IL-6 inhibitor, anti-IL-12 or IL-23. The names I will say, because whenever you hear these names, they will look familiar to you. Ustekinumab, anti-IL-17A is secukinumab and is very much in use and is available in India. The other one is ixekizumab, anti-IL-17 receptor is brodalumab, anti-IL-23 is guselkumab. Now, the two therapies you have also named, they are B-cell targeted therapies. Rituximab, which is so commonly used by us, they are anti-CD20, and B-cell growth factor inhibitor, that is belimumab. The T-cell targeted therapy, which is anti-CD80 or 86, which goes by the name of abatacept. Friends, this is Biologic Part 1 seminar. The next webinar is going to be Biologic Part 2, where we will be including small molecules. We will be including the B-cell and T-cell inhibitors as well. Well, management of rheumatological conditions are, as I have already said, that the systemic anti-rheumatic drugs are to be used, which are known as disease-modifying anti-rheumatic drugs. Now, the factors which determine the choice of DMARD therapy, which perhaps Dr. Manish Khanna also wanted you to know, was there are factors in the disease and factors in the patient. So, the disease factors are severity of disease, duration of illness, bad prognostic factor, presence of deformities. Patient factors are comorbidities, infection, age, compliance, affordability, safety, and friends, most important of this all, many of our patients are young. They are going to be parents. So their fertility plans have to be taken into consideration. This becomes so very important. Well, unfortunately, Manish is not here, but we will be discussing the use of biologic in early rheumatoid arthritis. I will be dealing with it myself in my presentation. Well, spondyloarthropathy and the intestinal and hepatobiliary disease. Friends, now this hypothesis is very important, which is not only a hypothesis, now it is almost proved to the extent that bowel is a source which also affects the joints or even the skin. So, as far as the hepatobiliary disease is concerned, the last point, number 4, it is autoimmune hepatitis known as AH, which represents polyarthritis and positive ANA. They can mimic even systemic lupus erythematosus. Well, 25% of patients are associated with inflammatory bowel disease, most commonly in those with extensive colonic involvement. So the colon is the seat of involvement of IBD, constitutes 25%. Now, even otherwise, consider a bowel disease in any patient with an intermittent inflammatory arthritis, regardless of presence or absence of gastrointestinal symptoms. Number 3, Episodes of peripheral spondyloarthropathy may or may not coincide with flares of bowel disease, while axial SPA occurs independent of bowel disease activity. Well, bowel disease associated with inflammatory arthritis, all of us are aware that IBD, interstitial bowel disease, is Crohn's disease and ulcerative colitis. So ulcerative colitis is IBD associated with spondyloarthropathy, all these two. Microscopic colitis, which is also goes by the name of lymphocytic colitis and collagenous colitis. Then infectious gastroenteritis, Whipple's disease, where also the GIT involvement is associated with peripheral joint arthritis. The celiac disease, bowel associated dermatosis arthritis syndrome are various areas where enteropathic etiology has to be there. Now, with this background, I would request Dr. P. Dhansekhra Raja from Coimbatore to talk about why gut involvement influences rheumatology management. I stop share. Dr. Raja.
Thank you, Professor Jha. Good evening, all faculty and viewers. I'm going to talk about the gut involvement and the role of gut involvement in pathogenesis of the rheumatoid arthritis. So it involves these topic subheadings. What you need to know about human microbiome, what is dysbiosis, and the role of gut in RA pathogenesis and therapeutic importance of this issue. So first of all, we need to know that human microbial ecosystem is quite vast, and more than 1,000 trillion bacteria are present in the distal gut. The microbes are present in the skin, lungs, oral cavity, perineum, and multiple places, and they play an important role in disease evolution. So if we look at the various disease in humans, there is a large role played by the microbiome, including autism spectrum disorder, hypertension, kidney stone formation, insulin resistance, asthma and allergy, metabolic syndrome and obesity, inflammatory bowel disease, rheumatoid arthritis, colorectal cancer, and the list is never ending. So the genetic predisposition and environmental factors, including diet, has been shown to trigger rheumatoid arthritis, and dysbiosis plays an important role, and bacterial lineages in the which causes change in the alteration in the microbiota in the gut leads to host immune profile changes and onset of rheumatoid arthritis. So the alteration of gut microbiota has been proved beyond doubt that there is change in the microbiome in the gut, which leads to triggering of the systemic immunity and onset of the rheumatoid arthritis. And the commensal is replaced by different strains of bacteria which directly invade the immune system. And alteration of immune system leads to activation of rheumatoid arthritis. So how do we know this? They have this SKG mice, which develop arthritis when they are subjected to specific type of immune challenge. They develop spontaneous arthritis, and they are used to investigate the role of cytokines and all this interleukins, and they can create the rheumatoid arthritis in the lab. So when you expose these microorganisms, these mice to specific gut bacteria or these T helper cell with immune activation, they develop arthritis, and these have been used to investigate the role of gut in rheumatoid arthritis. So there are three different phenomena by which the gut can trigger and activate the pathology. First is release of pro-inflammatory metabolites like interleukin 12, 23. Second is impairment of intestinal mucosal barrier, which leads to autoimmunity and direct invasion of the bacteria, and molecular mimicry of autoantigens. The antigen presenting cells in the gut are exposed to this bacteria, and they are able to trigger the autoimmunity. So these three phenomena can be seen in this picture. So the gut homeostasis is lost the commensal is replaced by some pathological strains, and they weaken the tight junction in the gut, leads to inflammation in the mucosa, and allows the bacteria to enter the mucosa, and they stimulate the antigen presenting cells, which leads to activation of autoimmunity. And the autoimmunity is again reflected in the joints, leads to destruction of the joint cartilage and other interleukin release, leads to further damage. They also mimic the antigen presenting rheumatoid factor cells. It can be seen also in periodontal disease and lung involvement. We see a lot of patients with reactive arthritis having autoimmunity, and they have reactive arthritis. This is a similar mechanism. Periodontal infection, gut infection, lung infection can cause reactive arthritis. So these are different studies which have shown that the oral bacteria can affect the immune mechanism and leads to citrullination of the macrophages, which will again lead to immune activation. So if you look at specifically what happens in early rheumatoid arthritis, there are some species of bacteria which is increase in number, and some beneficial bacteria reduce in number. So Provatella copri, lactobacillus species are increased, and bacteroids and bifidobacterium and Eubacterium rectile all reduced. So these are protective bacteria. These absence of this leads to stimulation of the activation of the rheumatoid arthritis. In active rheumatoid arthritis, Lactobacillus salvarius and Colonicella, all these species is increased. So these invade the mucosa, activate the immune mechanism. This autoimmunity leads to joint destruction. And also they release cytokines from the gut mucosa, like interleukin 1, 6, and 17, which again affect the joint as per se. So if you see Bacteroides uniformis, which is very important for the stability of dermatan sulfate. Once this bacteria is reduced, this leads to disintegration of the dermatan sulfate and chondroitin sulfate, which is part of the cartilage. Again, if there is increase in E. coli, that leads to activation of certain amino acids like L-arginine and ascorbate, which leads to bone loss and decrease bone mineral density, periarticular osteolysis. So again, dysbiosis with these bacteria can directly inhibit the osteoclast and cause bone-resorption. So how do we modulate these gut-induced problems? There are two ways. One is use of oral probiotics. Second is fecal flora transplantation. So again, we can see there is role of some biologics, what we use like methotrexate, DMRDs. Again, they have a positive reinforcement on the gut. So when we take this methotrexate, sulfasalazine, hydroxychloroquine, they restore the normal gut bacteria and leads to positive response. So they work symbiotically, creating a good therapeutic response. If you look at probiotics first, studies have shown that in rat model, use of lactobacillus cc and acidophilus reduced the arthritic inflammation and pannus formation and cartilage destruction. So it has been shown in the multiple rat studies, but some species like Lactobacillus reuteri and Rhamnus actually do not cause this effect. So need to be very specific about the probiotic what we are using. So these are in animal studies, but more human trials has to be done, and specific species has to be used to have the desirable effect. Second, fecal microbiota transplantation. In resistant, there are case reports there where there is refractory RA, fecal microbiota transplantation from healthy individual has reduced the effect of the disease and caused remission. And there are few case reports, but further studies has to come, but this is on potential area of future research. Second is indirect regulation of gut microbiota. So when you start using methotrexate, there is remodeling of the gut microbiota. So in turn, it increases the bioavailability of methotrexate. So they work symbiotically. The methotrexate restores the normal gut commensals, and it increases the absorption of methotrexate and bioavailability of these drugs, and partially restore the gut microbiome. Sulfasalazine again has been shown to substantially reduce the fecal counts of Clostridium perfringens and E. coli. Again, if you use sulfasalazine in patients, the total aerobic bacteria, bacteroids, all these counts are increased. When you use etanercept, there is specific increase in Clostridiaceae species, but hydroxychloroquine has increased the total intestinal bacterial richness and diversity. So there are different therapeutic drugs have different effects. Coming to dietary fiber reduces the gut leakage. Drugs like omega-3 polyunsaturated fatty acids restores the intestinal milieu, and high salt diet increases the inflammation and therefore pro-inflammatory. So diet should be less in carbohydrate, and a low salt diet is better. Diet rich in omega-3 polyunsaturated fatty acids are beneficial. So typically a Mediterranean diet is very beneficial. They have short chain fatty acids, and especially the presence of butyrate is very beneficial. So Mediterranean diet is typically rich in fruits, vegetables, and with moderate consumption of it and low consumption of red meat is beneficial. Studies have shown that DA score has improved after this diet when you compare to control group. Depletion of amino acids like glutamine and tryptophan or depletion of zinc resulted in increased gut permeability. Vitamin D and polyphenols improved the expression of tight junction. They are all beneficial. See, all these are part of the Mediterranean diet. A Western diet, which is rich in fatty acids and alcohol, has a negative influence on the bacterial flora. So when you combine these approaches, there is a lot of therapeutic benefit. It has been shown that blockage of zonulin with larazotide, which is a drug which prevents the onset of arthritis in mouse models. So this can be a future therapeutic product for gut dysbiosis. So concluding, gut microbiome dysregulation is associated with dysregulated immune tolerance and RA development. Change in the gut microbiota can precede the onset of rheumatoid arthritis and are related to different stage activities. Analysis of gut microbiota composition can also predict susceptibility and has become a useful method to predict the control of rheumatoid arthritis incidence. And there's mounting evidence that targeted modulation of gut microbiome can alleviate rheumatoid symptoms, and personalized treatment approach with the patient-specific microbiome profile can increase drug efficiency, lower toxicity, and improve outcome. Thank you.
Thank you very much. Right. So, Dr. Raja, you have not only discussed about the detailed pathogenesis of gut involvement along with its osteoarticular involvement, the dysbiosis being the basic pathology. You have also discussed about the various diets that could be of help, and that will be a great help to all of us. Now, the latest management of dysbiosis has been fecal microtransplantation, and this is an area in which a lot of research is going on. So thank you very much.
Thank you, sir.
Now is the turn of methotrexate man. Definitely Dr. Raja has touched upon some aspects of methotrexate, but still lot has to be there about why add methotrexate with biologics. Professor Chinmoy Das from Dispur. Sorry, I will stop sharing.
Yes, sir.
Right.
Sir, is it visible and
Yes,
am I
yes,
audible,
you are
sir?
audible and visible.
Thank you, sir. Thank you for a very good webinar. From the starting, as you were leading the IOA Orthopaedic Rheumatoid Arthritis subcommittee, so I knew it is going to be a vibrant one this year. So thank you for this opportunity giving to me, sir. So I will just say about methotrexate, that why we should add methotrexate with the biologics. So just going by our past speakers, methotrexate is nowadays, it is considered as the anchor drug of rheumatoid arthritis. It was developed in the 1940s as folic acid antagonist. So basically what it does is it calms your immune system, stops the cells from growing, all the T cells, B cells, and it is mainly excreted by the kidneys by glomerular filtration and tubular secretion, and it is metabolized in the liver, and 10% of the drug is excreted in the bile. But it has got side effects, and mainly the side effects are gastrointestinal, around 20 to 65%, of which nausea is around 92% and vomiting around 31%. Abdominal cramps, black tarry stool, blood in urine and stool, increased heart rate, itching, rashes, reddening of the skin, hair loss around 3%, sores in the mouth and lips. Although these side effects, they are present with most of the conventional biologics, conventional DMARDs, or your other DMARDs, they are targeted DMARDs, also has got these side effects. But it is very important, methotrexate, because a patient can stay on methotrexate for around 20 years. That's a very big advantage for people who are treating rheumatoid arthritis. And the success rate is around 65 to 95%. This is how it acts. It actually inhibits your dihydrofolate reductase, thereby reducing the folic acid, means stopping the folic acid metabolism. And the dihydrofolate cannot be converted to tetrahydrofolate, which is an active form of folic acid. Thereby, it decreases the DNA metabolism, decreases the pyrimidine and purine synthesis. It also inhibits an enzyme called ACAR transformylase. This is 5-amino-imidazole carboxamide, 4-carboxamide radionucleotide transformylase, whereby it increases the ACAR extracellularly, and which in turn increases the adenosine. This is a pathway, adenosine signaling pathway, which has come in focus, and methotrexate, mainly the function, the action of methotrexate is by this adenosine signaling pathway, whereby there is downregulation of your pro-inflammatory cytokines, inhibition of apoptosis, as well as inhibition of your neutrophil and lymphocyte chemotaxis. So why methotrexate? See, actually, there are no strict guidelines that which conventional synthetic DMARD to start first. But methotrexate, of all the conventional DMARDs, it has got a rapid action, rapid onset of action, and patient tolerance, cost consideration, and ease of once weekly administration of methotrexate is the DMARD choice. It is widely prescribed in the world, and when used more than 1 year, it has been found in several studies that it decreases the mortality by around 70%. So methotrexate, the drug, is given once weekly. Convenience is it can be taken orally, around 7.5 to up to 25 to 30 milligram you can give once weekly. It is taken orally, but you can go with subcutaneous injections or intramuscular injections. It has got side effects, mainly GI side effects and hepatotoxicity, but monitoring is very important, where you go for blood counts and LFT every 6 to 8 weeks, chest x-rays annually, urea creatinine for renal function. As I have already said that it is excreted by kidneys and it can accumulate there. So urea and creatinine 3 monthly you can go for, and sometimes liver biopsy, because one of the major complication of methotrexate, long-term methotrexate use, is your cirrhosis of liver. This is how it works. So with adenosine receptor present in the cell wall, it goes intracellularly, it inhibits your ACAR transformylase enzyme, which inhibits your ACAR conversion to formal ACAR, and also has got an inhibitory effect on adenosine deaminase, whereby it increases the adenosine, and this adenosine goes extracellularly, and this adenosine is not converted to inosine. These are various receptors present in the cell membrane. They are classified as A1, A2A, A2B, and A3. And these have got specific actions, these receptor molecules, because mainly the A1 and A2A, these are very methotrexate friendly, and they help in they act via the adenosine signaling pathway, and they reduce the adhesion of your neutrophil and macrophages, as well as the A2A, it reduces your inhibition of there is increase of, this is another theory, that superoxide anion production, which also goes for apoptosis of the cells. There is a conversion of macrophages, which are M1, the macrophages, they are divided into M1 and M2. So the transition from M1 to M2 is reduced. This M2 is your inflammatory type of macrophages. Then it inhibits the T cells, inhibits B cells, and increase the production of collagen 1 and 3. So should conventional DMRDs used singly or in combination? See, combination therapy has got an inherent appeal for, especially for us orthopedic surgeons, and combination DMARDs is specially effective if they include methotrexate as an anchor drug. Combination methotrexate with leflunomide they are acting synergistically, since their mode of action is different. And these are the studies which support it. But methotrexate is not to be taken with trimethoprim, and adalimumab, with adalimumab, it increases life-threatening infection. So we have to be careful using this drug with other biologic DMARDs. So when methotrexate fails, if it is failing, then what are the options? We have got around 4 options. We can switch to subcutaneous route, or add conventional DMARDs, corticosteroids, hydroxychloroquine, leflunomide, or sulfasalazine with it, or add a biologic agent, or switch to tofacitinib. That's a JAK inhibitor, as Sir has already said in his introductory remarks. Regarding biologics, I will not say more because this is not my subject. It has already been taken by Professor Ranjeet Singh and Sir also in the introductory remark, but they also inhibit the T cells, B cells, as well as the macrophages. So methotrexate with biologics, it has got some mechanistic advantages. So it increases the effectiveness of biologics. It reduces antigenicity against the anti-drug antibodies, then prolongs the time you can stay on biologics, and reduces clearance of biologic agents, that is longer persistence of the treatment. These are the studies which support this theory. Recently, in the 22 to 2022, we have got EULAR guidelines. These guidelines come up every 3 years, and they have clearly said that you can add methotrexate with, if it is not responding after 3 months, the biomarkers, poor prognostic factors are present, then you can directly go and add it with the JAK inhibitors. Thank you, sir.
Thank you. Thank you very much, Professor Chinmoy.
Yes, sir.
All right. So you have already discussed about the monitoring is very important, and you have told us in greater detail about the adenosine cycle through which it finally works. Well, as far as its use with adalimumab is concerned, there has to be a word of caution as told by you, but then it is not that it is never to be used with adalimumab.
Yes, sir.
Rather, people advocating use of adalimumab, they say that you must use it, then the adalimumab is more effective. If you do not use it, maybe the dose of adalimumab from bi-weekly, it may have to be once weekly. So the dose may need to be increased. So only thing, infection is a definite complication of not only use of these two combination, it is true for all the combination, or maybe even in cases of monotherapy. So we have to be alert on that count. Now, this definitely is a gold standard drug, and you have mentioned that various guidelines also mention use. But the most important thing you have said that anti-drug antibody formation does not take place if it is added with a biologic. This
Yes.
is the most important aspect. And one thing, in monitoring, you have said the chest X-ray and maybe at a later date, liver biopsy is important. The most common complication with methotrexate that can affect the lungs is interstitial lungs disease.
Yes, sir.
So to prevent this complication, it should be added on the same day with little steroid. So a steroid weekly along with this should be advocated to prevent the development of interstitial lung disease. Now, regarding use of simultaneous folic acid is an area, controversial area. People say that folic acid should be given, supplemented rather, should be supplemented, and it should not be given on the day that methotrexate is being given. Now, all the points are debatable. Now people say no harm, give it. Now people say you may use it daily. Some people say use it only twice daily. But the most accepted path will be that use them not on the day that you are using them, and minimum use twice or thrice a week. You want to make some comment?
Yes, sir. Sir, regarding this folic acid, and it is debatable, as you have already said, sir. See, folic acid, it's a synthetic vitamin B9. The natural product is your folinic acid, sir. So it has been seen that folic acid, no doubt methotrexate is a drug which is discovered or invented against as a folic acid antagonist, but it has found it is also relevant in case of rheumatoid arthritis. It has been found in the late 1980s that it acts against rheumatoid arthritis also. But this folic acid, actually just 5 milligram, 1 to 5 milligram of folic acid is given, and that is not able to reverse the changes of methotrexate. That's why people say nowadays that it can be given. But This folinic acid, the naturally occurring benign vitamin, so it should not, it means in high doses, it reverses or stops the action of methotrexate. That's why folinic acid, it can be used in from 15 milligram to around 150 milligram till your methotrexate level comes down below 0.5 micrograms of per deciliter of blood. So, but folinic acid has got the capacity to reverse the actions of methotrexate. But folic acid as such, it doesn't have that capacity in the normal dose, whatever we give 5 milligram daily, sir.
Right. So it is our universal opinion that folic acid should be given.
Yes, sir. It can be
in
given.
dose of 5 milligram. Preferably do not use it on the day that you have given methotrexate to be more safe.
Yes, sir. Because methotrexate also, the peak plasma level, it reaches at around 1 to 2 hours just after the medication, oral medication, and it remains in circulation only for 24 hours. So by that time, it goes down from the circulation intracellularly.
Right. So thank you very much.
Thank
now, Dr. Raja has already spoken about IL-1, IL-12, IL-23, TH17. So all these cytokines and TNF-alpha we have been discussing from the first topic. So what are these cytokine and what cytokine inhibitors do? We have Dr. IOA Rajamani, who has primary interest into spinal surgery, but it is our affection that we always pester him to be here, and he is there. So he will primarily speak on all the cytokine inhibitors, most of them, and in the end he will also show some of his spinal surgery cases. Dr. Rajamani, please.
Thank you, sir.
I will stop here. Right. Yes, you are there now.
My screen is shared.
Yes.
Rajamani, welcome.
Yeah, welcome.
Yes, Dr. Dilip, you are audible.
I know. Yeah. Good evening to all and Jas sir. And my talk is mainly on cytokine inhibitors. And my talk preface is what is cytokine, types of cytokines, pathology, role of cytokine inhibitors, and role of spine surgery.
Rajamani, your slides are not shown.
Pardon?
Your slides are not visible.
You share the screen first. Share the screen first. Right. Yes.
Now
yes.
better. Thank you.
Go ahead.
Yeah. This I just go to this
Slideshow. On the top, there is animation and then slideshow. On the top, red. Top red. No, go on the top red. No, you were all right. Again, share the screen.
Now it is there?
No. It has backed out. Share the screen again. Yes. Now on the top, there is a red border. In the red border, initially it is file, then home, then insert, then design, then transition, then animation. After that, slideshow. Yes, press it. And then on the left side, from beginning. Yeah. And now you will be there. Right.
Yeah. Thank you, Jas sir.
Oh no.
And my talk preface is very basics. I'm going to talk about mainly on very basics. What is cytokine, types of cytokines, and what's the pathology there, so that we can know what is the role of cytokines in that, so that where the cytokine inhibitors act on that, and finally the role of surgery. Start with cytokines or small secreted proteins, as we all know. It is synthesized and released by the WBCs and tissue macrophages. It mainly mediate and regulate the immunity, inflammation, and hematopoiesis also. It involves an intracellular signaling during immune response. Either it stimulate or suppress the functional activity of the blood scavengers or the fibroblast or endothelial cells. There are 200 cytokines have been diagnosed so far, and it produced from immune and inflammatory responses, and it is closely and transiently regulated and acts by binding specific receptors on the target cells, and its actions can be either endocrine or autocrine or paracrine. And there are cytokines, there are 6 or 7 cytokines are available, but the rheumatology, we mainly, even though other thing has got some roles on that, but mainly interleukins and tumor necrosis factor, and particularly alpha, TNF alpha is more concerned with the rheumatology. And because my next speaker is going to talk on interleukins, I will not mainly touch upon those things. But these two things are very important. Very cytokines are very important for the concern with rheumatology. And coming to the interleukins, it is mainly T cells and mononuclear phagocytes, and its signal communication, and also its cellular division and differentiation. That is 35 well-known interleukins have been identified, and many more are pipeline. And they act on the receptors. There are 4 types of receptors are available, and mainly concerned with the type 1 receptor is more involved in rheumatology than other things. On binding the cytokines to the receptors, there is a cascade of events occurs, either which induct or inhibit the transcription of genes and act through the ligands, so that the structural damage is done. And mainly TNF alpha and IL-1 and 6 is involved. The other 2, my subsequent speaker will talk on this. And arthritis basically, as you're all aware, is a chronic systemic inflammatory disorders, mainly by autoimmune reaction, and T cell is a pivotal role in destruction. Both as and when the action is initiated, the T cell and CD4 plus appear in the joint, and it activates the synovial capillary endothelial cells, and migration of other endothelial cells follow. And arthritis has got the 4 stages. One is induction, another one is inflammation, another one is a self-perpetuation, another one is a destruction. On induction, early phase, it initiates the autoimmune reaction. Mainly, it activates the APC through the TNF alpha 6 and 23. And the second stage, these APC activate the T cells. And the third stage is the self-perpetuation, that is the macrophages and T cells acted through the TNF alpha 6 and 7. And finally is the destruction stage. So the drug action can mainly take place either in the early phase of induction or in the third phase of self-perpetuation. This cytokines work. So another something that happens in the lymph node, that happens in the circulation. This happens in the lymph node. As and when the initiation takes place, once again the synovial cells are activated, and then subsequently the structural damage happens. And mainly, as I told you earlier, because of the infiltrated T cells and macrophages secretes alpha and other interleukins, so that it acts on the cartilage, it acts on the cartilage, it acts on the osteoclast, and then it produces the fibroblast, and ultimately venous formation occurs. So all these 3 things basically, the structural damage is cartilage destruction, osteoporosis, and venous formation. And TNF induced cartilage and bone resorption by releasing collagenase on synovial cells, and the expression additions of the molecules which inhibits the proteoglycan synthesis. So ultimately it leads on to osteoporosis. The plate-derived growth factors stimulate the fibroblasts, which complete the show, and then whole thing is fibrous, and then you end to the fibrous ankylosing and through the venous formation. So this is at the final stage, all these three cytokines, and particularly TNF alpha and other two interleukins, which my subsequent speaker will talk on, have a great role in policing destruction. Coming to cytokine inhibitors, it's mainly TNF alpha, IL-22, 23, all are pro-inflammatory cytokines. They block the action either by receptor blockade or neutralizing the activity of the cells. And so these activate the B cells, produce auto antibodies, and at the same time, the activation of macrophages, it produces inflammatory cytokines. So these cytokine inhibitors are both in the earlier stage as well as in the third stage, so that when the macrophages induce all the three cells, which is depicted in the picture, a cartilage cell, a fibroblast, and then the osteoblast. These are all the basic steps which happens, and this acts on the earlier phase and middle phase, which give an idea the cytokine TNF alpha can be used even in the early stage itself. At the same time, it not work well in all cases because there are other cytokines like interleukin and all is involved. So by giving a TNF alpha alone may not be sufficient to work out in all the cases. So it has to be substituted with other cases as and when it is necessary. Now the cytokine inhibitors, there are two. One is available, that is mainly at the stage 1 of this group of drugs. All other things are on the pipeline, which acts on the earlier stage, and the next group of cytokine inhibitors act at the third stage of disease. All others drugs which is shown in the slides are all under the pipeline, has to be established on its own. Now, who can get these cytokine inhibitors? Not responding to DMRDs or early or even in middle stage of the disease. That's why I insisted on the pathology of the rheumatoid arthritis. If you understand that, we can agree that early and middle stage of the disease needs cytokine inhibitors. And the caution is, as usual in any other biologics we give, all these try to avoid infections, diabetes, tuberculosis, and all the same protocol continues with the cytokine inhibitors also. And now, in the future, what is on cytokine therapy in future? The oral delivery of the genetically induced bacteria called actobiotics produced by Lactobacillus bacillus. And the classical example is recombinant human IL-10 for interstitial bowel disease. For example, it's Chinmoy. Probably in the due course of time in future, other TNF alpha can come like this, sometime like in the future. That is what there in the pipeline. Now, the cytokine inhibitors will not work when there is obviously a deformity or sagittal. Once the structural damage develops, probably we have to go treatment for the structural damage, and cytokine inhibitors mainly to arrest the progress of the disease. It cannot do what the already damage has been done. For example, deformity or sagittal damage of the spine and fracture. Surgical treatment is the choice in these situations. And deformity correction is very, very important because it hampers your day-to-day activities, because the head is totally flexed, the vision may be a problem. And when there is a fracture, it can work cord compression, can produce a pain and neurology. And it is technically difficult, of course, to do a surgery on a fully gross deformed spine with a high risk. Of course, with the neuro monitoring and all other advanced gadgets, we carry on with this like this. Next is fracture can occur due to tibial injury. Because of the osteoporosis, if the tibial injury can cause a fracture, which is highly unstable situation in arthritic patient. It is something like a chalk-like fracture, where it can easily go for instability. A pleural hematoma itself, without a fracture, can cause a neurological deficit, and surgery is the choice. Of course, we have to decompress and stabilize a long construct that is osteoarthritis. So, take-home message is, disease progression can be reduced even in early stage and middle stage, and cytokine inhibitors are the best alternative when DMRD do not work. It is a targeted therapy and highly selective action. May have to be continued with the other cytokines, something like interleukin, which is concerned. And the deformity correction needs surgery with the risk and precautions. Fractures with the neurology to be treated surgically. And epidural hematoma, most of the time it is missed because obviously there is no fracture. But in these cases, trivial injury can produce epidural hematoma, can produce a fracture. And if there is a neurological deficit in these types of individuals, better do an MRI, confirm, and proceed. Thank you so much.
Thank you, Dr. Rajamani.
Yes, sir.
Right. So you have very nicely discussed about what cytokines are and what the various cytokine inhibitors can do. Now it is the turn of further explaining regarding TNF alpha and Dr. S.S. Amarnath. Now it will be your turn to dilate the TNF alpha inhibitors role. Dr. Amarnath, please. I stop share.
Thank you, Dr. Jha.
Welcome.
Right.
Welcome, Amarnath.
Dilip, thank you.
Good evening.
And Happy New Year to each one of our delegates and faculties.
Thank you.
Wonderful, wonderful. I'm going to share the screen now, and hopefully that should be there. And I will take that. Hope all of you are able to see my screen now.
Yes, very clearly.
And I'm putting on the PowerPoint presentation.
And same to you.
Dilip bhai, can you probably mute yourself?
Yes, he will do. He will mute. Right.
Wonderful. Thank you. Thank you. This is a very, very interesting and to bring out the orthopedician in every orthopedic surgeon. This entire focus is on that now. Today, all the speakers have given us a step ahead and clarity of treatment if one is scared to talk about it or even to try and all even to treat the patients. Definitely, it makes a big difference when once you have the information in hand, you become a better doctor and the patients are at ease when once their pain is relieved. So with that in mind, a small introduction on that, and Rajamani, Dhansekhra, and Ranjeet, Jha sir, all of you have given a very good clarity on each step of that. 6 to 8 minutes is a very short period. I'll give you a very short, clear-cut image and very easy to understand and very simple terms. I hope I don't want to confuse you, but definitely we'll be at large available and discuss further. Alpha TNF. TNF, what is that? Tumor necrosing factor.
You have become mute. Amarnath, your voice is not audible. Amarnath, your voice. Amarnath, your voice is not audible.
We're talking about
right.
Basic. Sorry. There's an incoming call. Sorry about that. There's an incoming call. So now, basically, what we need to do here is we need to understand on the arthritis part and polyarthritis, psoriatic arthritis, and AS, the ankyspine, gives us a very big challenge to treat. Now, with that in mind, we need to talk about the little function of these things. It stimulates the endothelial cells and to express the addition of the molecules, and white cell has an inflamed synovium on the skin. So this is where the whole challenge comes in the induction of the cytokine response with be it IL-6, IL-1, or things like that in a very simple, small example. Now, this is where when the synovium is affected, because see, rheumatoid arthritis is a systemic condition. It's not just a joint problem. Joint is a presentation of the challenge that we have in the systemic response that is coming in the immune function of the body. So that's where we need to look at that. And then we need to look at how best we can control those cartilage destruction and fibroblast proliferation to be taken care. Now, in a joint pathogenesis of a destruction, what happens? inflammation is there, cell infiltration happens, then articular damage. We, being orthopedic surgeons, are the only doctors in the world who have the ability not only to treat, we also feel the joint, see the joint, and we have the ability to replace a joint. But thankfully today, there are other things where we don't need to, probably do a replacement in a big way. So that we need to look at that in taking care. Now, in the pathogenesis of RA, all of us know the synovial membrane is very badly damaged. So we need to look at that, how we can. Now, alpha TNF and IL-1 is the biggest challenge that we need to treat and talk about. Here, this was the first, drug which was available, which has been made available for us just over 2 decades ago, in fact. India, it's about 15 years plus. We have it. And etanercept was the first molecule where it was augmented to treat rheumatoid arthritis in a big way. And this has been accepted globally. Thankfully now, not only biologics, we have biosimilars as well. Apart from that, there are quite a few which are made available, alpha TNF inhibitors. In India, by and large, we are using 3 in a majorly fashion. I'll check on those things: infliximab, etanercept, and adalimumab. These are very well accepted in India and available both in biologic forms and biosimilars, which is a boon for our patients in terms of affordability, and obviously the action need to be kept in mind. Let us talk about the mechanism of action of these 3 drugs. And here, etanercept works a little differently. Now, what happens when there is activation of the cell happening? So this is where the whole challenge comes into. The signal takes care. Imagine if there are multiple signals coming in, and when once you and I add those monoclonal antibody, there starts to have a different action. But here, we need to understand and make sure that we need to block that much bigger. So alpha TNF receptors will block that signaling pathway and then avoid stimulating huge amount of pro-inflammatory reaction in the body, so that it reduces the pain, reduces the inflammation. As Professor Jha was talking in his first slides, he also very clearly said these are targeted therapy. So it works in the cell, within the cell, in the DNA, and then takes the whole thing in a big way. So taking the alpha TNF, etanercept, infliximab, and adalimumab, they all are just over 2 decades now. And it's very well accepted, and we don't need to majorly worry about a big way to monitor a lot of things. Yes, the dosage and other things will come there. Here, as the previous speaker was talking about, we can definitely add, methotrexate. Dr. Chinmoy was talking about it with etanercept and infliximab. In adalimumab, we got a little cautious, but let us not worry. It's been very nicely explained earlier. The first biologic, what happens and where do we go? Here, little on the structure, and I don't want to confuse you. There are a lot of other things that can be talked about. I will just rush through that. And here, it inhibits the alpha TNF tumor necrosing factors, both alpha as beta. But here, alpha is the most important factor coming in. Now, the indications for us are rheumatology and non-rheumatological therapy as well. The dermatologists are using in a massive way for the plaque psoriasis. You and I get to treat psoriatic arthritis. But here, we need to understand it's also made available to be treated for both seropositive as well as seronegative arthropathy, which is very important for us in our treatment, and diagnosing it early so that we can avoid the kind of complications further. And definitely the replacements can be avoided in a massive way. Now, the dosage is very simple, bi-weekly, 25 mg can be given twice a week as a subcutaneous dose. 2, 50 milligrams is pretty good once a week, and then they have a very good response. Addition of methotrexate has been definitely be an adjunctive in a combination therapy. I do have a few of my patients with methotrexate, but many of them are on etanercept. So 50 milligrams as a subcutaneous dose once a week can be given. And the advantage, when there is a remission, we could titrate and we could probably stop as well. And Dhansekhra very nicely explained about the probiotic. I have a lot of my patients on probiotics, so they do have a better response in terms of remissions for us. So here, similarly, I wouldn't want to take too much of that. It's very clear, 25 or 50, very, very easy. Now, coming to adalimumab, the next alpha TNF blocker, this is also similarly available, but main indications have been like in infliximab or even here, Crohn's disease has been a major, major advantageous thing. So many of the patients do come across with the, bowel pathology with arthritic response. So naturally, we need to reserve those things for them in a big way. And many times we need to definitely ask about the bowel habits when we're talking about arthritic patients. That's a different subject altogether. Here, the dosage is a little variant compared to your etanercept. What we do here is we need to give them a loading dose sometimes of 80 milligrams, or if not, at least 40 milligrams on a weekly basis. We need to start that because loading dose is important to reduce that acute high inflammatory response, and then maintenance can be done. So this is one thing which we need to be taken both in rheumatoid as well as in the psoriatic conditions, as well as seronegative arthropathy. Now, coming to inflexi, again, mainly given in by the gastroenterologists. Now it's been taken over by dermatologists, rheumatologists, and obviously now with rheumatology interest with orthopedic surgeons. Now, this can be used both in adults and pediatric dose as well. The other speakers will come on. So this is very, very important for us in terms of usage and the indications. Here, the dosage is little variant compared to the etanercept or even adalimumab. Here, if we talk about 3 milligram per kg body weight, and we give it as 0, that is today, and then second week and 6 weeks. And then we repeat that once in a few weeks, maybe a couple of months, so that the remissions can be, taken very simple. This is in rheumatoid arthritis. Compared to rheumatoid arthritis, when you're talking about ankylosing spondylitis, the dosage is a little variant. We give it a little higher dosage, 5 milligrams per kg body weight, but the pattern remains almost similar. 6 to 8 weeks, we probably repeat that, and then people have come out with a very good response. The treatment for ankylosing spondylitis and psoriatic arthritis or even plaque psoriasis is similar, not much of a difference there. As there is a huge amount of efficiency and the patient studies that we need to be understanding. Is there, what should I do? Which one do I give? A lot of questions that you need to understand. Third, financial. Fourth, is there any reimbursement facility like an insurance and things like that? Thankfully, with IRDA, I've worked with 15 years now with the insurance segment, and all these drugs, both biosimilar and biologicals, are made available by the insurance segment. Unfortunately, it is still not available for us in a big way for the Ayushman Bharat for almost 40 to 45 crores of patients, but we are working on it and making sure that this can be made available even at that level, because that is a large segment which is neglected. So now, safety first, because all these immunosuppressants come with a high prevalent suspicion, of infection coming into picture. So we need to protect our patients. Basically, tuberculosis is one of the most fearful things. So before we give this treatment, we also treat the infection, if at all, if they have, or we also make sure that we don't have the active disease, and then we start this. So that's very important for us. And while on the treatment, mycobacteria has a very big upper hand. So we need to make sure that we take care of that. That is the biggest thing. There are a lot of studies. I'm going to just run the slides through, and then you and I can go through that in a big way. Now, infliximab, adalimumab, etanercept. So now, where and how? This study, which is done just in 2 years ago in rheumatology from Oxford in UK, it was printed. And here we talk about how well the response have been given. Similarly, here, etanercept has an upper hand there, comparison between other things, similar, not major difference, but definitely etanercept has given a better understanding. Here, definitely the 178 patients were taken in the study, which was printed again just over under 2 years ago, and 8 years follow-up has been done. And the kind of complications and the kind of withdrawal when once the patient was taken out, how did the response, and it's very, very clear for us here in all the charts. So this is very, very important for us. And the dosage variation with etanercept has been very well accepted. And while coming into different studies, I'll not waste your time there. I will take the next slide. Similarly, that has been taken care and given to us in a majorly fashion. The advantage of etanercept is subcutaneous, unlike the infliximab, which is going to be IV and things like that. So naturally, this will be a better choice in terms of, and patient can be advised to take it at home because it comes in a device. And with this, I appreciate your time and thank you for that. I'm going to stop sharing. Thank you, Dr. Jha.
Thank you. Thank you very much for talking in detail about all of them. And in the end, you have rightly concluded that etanercept has so many advantages. But it is not always that one biologic is equally effective in all the patients. In your clinical practice, you will find that there are cases which have not responded so well to etanercept, have done dramatically well if you have given them adalimumab. And sometimes infliximab also gives very good results, but for the cost. Well, talking about dose of infliximab, I must highlight here the Western advocated dose is 5 milligram per kg of body weight, but Lieutenant Colonel Chaturvedi has extensive work done, and he says for our Indian patients, only 3 milligram per kg body weight, which is advocated for rheumatoid arthritis in Western world also, is good for spondyloarthropathy. Now, when we have started talking about the dose of a drug, I must tell you, I have used etanercept in more than 3,000 cases. And I have used them in only half dose, that is 25 milligram weekly itself. And they have all shown good improvement. It is very rarely that I have to use 50 milligram dose. There is a publication in Japanese journal which says that Asian subcontinent, the body weight is not as high as in the Western world. So the dose can be little lower for all the drugs. So thank you very much, Dr. Amarnath. Now is the turn of Dr. Ravi Gupta from Chandigarh, who has IL-1 and IL-6 inhibitors to be discussed. Dr. Gupta, please. I will stop share. Right. Dr. Gupta. Yeah.
So good evening once again, and thanks to Dr. Jha for making me a part of this team. And I'll be talking about IL-1 and IL-6 inhibitors. And I'll just keep a broad overview overview of these drugs.
Your voice is crackling, so you can shut off your video and then see what happens.
Is it okay now?
It sounds as if it is coming from a distance.
Okay.
Are you using an earphone?
No, no, I'm not.
No. Okay, so be close to the laptop.
Yeah.
Right.
So we all know that rheumatoid arthritis is a multi-system disease that affects joints and various other organs. So actually it leads to compromise in the quality of life, and also there is an increase in the mortality. The average life expectancy of rheumatoid arthritis patients is decreased by 3 to 18 years. That is what our literature says. Now, what happens in rheumatoid arthritis? Know that there are various cytokines, TNF alpha, IL-1, IL-6. They all work in various manners, maybe autocrine, paracrine, endocrine, and then they act on the synovial membrane, make the pannus, act on the osteoclasts, leading to the resorption of the bones, synovitis. Ultimately, there is destruction of the joint. So, if we look at the IL-1, the level of disease activity in rheumatoid arthritis, it directly correlates with the plasma and synovial fluid levels of IL-1. So this is a very, very important cytokine because there is a cascade of effects which it causes by these various mechanisms: monocyte activation, macrophage activation, fibroblast proliferation, and the chondrocyte activation and the osteoclast activation, and then the corresponding effects which are destructive in nature on the joint, the cartilage, as well as on the bone. Now, if we look at the anti-IL-1 drug, this is the anakinra is the drug. The trade name is the Kineret, and this is a recombinant human IL-1 receptor antagonist. And this is the study which is published in 1998 on 472 patients, and they have got randomized controlled trial, 4 groups, one with placebo, and then the increasing dose of this drug. And then it was seen that in comparison to placebo, there was a 43%, this American College of Rheumatology ACR 20 response rate was observed at week 24 in the highest dose group, which is, in comparison to placebo, was statistically significant. So that means this was a effective drug. So there are various other drugs which people have seen the efficacy in rheumatoid arthritis, but the main impact of the drug which is mainly used in rheumatoid arthritis is anakinra, and this is the various other things. The dose is there, the half-life is there, the given in a subcutaneous manner, and then these are the off-label uses also. So I won't go into the details of those things. Now we must know that in contrast to inhibitors of TNF, the improvements with anakinra were relatively modest. Perhaps it is due to its short half-life, and further, the inhibition of a single cytokine in the treatment of rheumatoid arthritis, it appears illogical, as we know that there are a number of other cytokines, especially IL-6, which have many other effects. But then people saw in various studies that if they combine the IL-1RA inhibitor with the TNF alpha inhibitor, then the efficacy was much better. So as a combination therapy, it has a better. So these are the various, other diseases where this anakinra has been used, but we are only interested in this symposium on rheumatoid arthritis, so I will not go into those details. Now we talk about the IL-6 inhibitors. And if we look at the IL-6, it is a very, very important cytokine for the body because in various infections and tissue injuries, it is so beneficial to enhance the host defense for the patient. But if its secretion is dysregulated and it is persistent dysregulated expression, it can be involved in the pathogenesis of various inflammatory and autoimmune diseases, including rheumatoid arthritis. So if we look at this picture, so there are two basic phases. That is the first phase, priming, and the effector phase. The IL-6 actually, it acts in both the phases. So it promotes the T helper 17 cells and also various autoantibodies, and then ultimately it leads to destruction of the joint. Another very important effect of IL-6, because we know rheumatoid arthritis is a systemic disease, so it is basically IL-6 which is so important to have effect on multiple organs, which may be liver, it may be cardiovascular risk. I told that the mortality is high. It is mainly because of the cardiovascular risk. Then there is a glucose, dysmetabolism, anemia, fatigue, and mood changes. They are all have been attributed to the IL-6. Now we talk about the IL-6 inhibitor. The commonest, there are two drugs, tocilizumab and sarilumab, and actually these drugs are recommended to be used only if there is a poor response to conventional synthetic or disease modifying anti-rheumatic drugs, or there is a TNF alpha inhibitors, they have stopped working. They can be used as a combination therapy or they can be used as a monotherapy. Now we know that there are a lot of comorbidities, as we saw in the previous diagnosis, this diagram of the pathogenesis of IL-6. It can be anemia, it can be high baseline IL-6 levels, intolerance to methotrexate, but there should not be enhanced risk of tuberculosis. So in those cases, we can use this IL-6 inhibitors. So these are the various other uses of IL-6 inhibitors, but now recently we have seen that in COVID, it has also shown its great role. Now, if we compare these two drugs, IL-1 and IL-6 inhibitors, the main difference is the anakinra has a modest effect, mainly because of its half-life, but it's quite safe. And IL-6 inhibitors are more effective for pain, stiffness, and other symptoms like mood, anemia, and even some protection against diabetes and cardiovascular. The risks for both these drugs are almost similar, including the increase in the infection. So we should be cautious when we are using them, especially those patients who are more prone for infection. So in conclusion, IL-1 and IL-6 inhibitors are the drug choices for moderate to severe rheumatoid arthritis, where the disease-modifying anti-rheumatic drugs have stopped working. IL-1 specifically inhibitors like anakinra has a short half-life, but has a potentiating effect when it is used as a combination therapy. IL-6 inhibitors are more useful in severe rheumatoid arthritis with comorbidities as a monotherapy or as a combination therapy. Of course, we must monitor for the side effects of these drugs because they are potentially toxic drugs. Thank you very much.
Thank you, Professor Ravi. You have very clearly delineated the limitations and the utility of these two drugs. And tocilizumab came into prominence during COVID days when even a general medical practitioner came to know that this is one drug which can help in situations where the COVID is not getting under control. Here in rheumatology, both of them you have rightly propounded should not preferably be used as monotherapy, rather they should be used as co-therapy. Now, next one is mine, where I intend to talk about use of biologics as per the guidelines that we have proposed for IORA and IOA for management of rheumatoid arthritis and spondyloarthritis. Well, Manish Khanna was to talk on early rheumatoid arthritis. So the early rheumatoid arthritis patients, let's once again, after all these discussions, consider what we have in our kitty. We are orthopedic surgeons, and we are very sure that pre-operatively we have given instructions what instruments should be available on the tray. So here itself, we have NSAIDs, anti-rheumatoid drugs, the disease-modifying anti-rheumatic drugs, the conventional synthetic ones, which are methotrexate, hydroxychloroquine, sulfasalazine, and leflunomide. The adjuvant drug is a glucocorticoid, preferably a prednisolone, and the non-biological conventional synthetic drugs. Apart from that, we have targeted synthetic DMARDs and biological agents, which are basically mainly TNF inhibitor first, and then there could be non-TNF inhibitors as well. Well, so the conventional synthetic therapy, the disease-modifying anti-rheumatic drugs, they can be used as either monotherapy or dual therapy or triple therapy. Now, there could be a patient who are DMARD naive patients. So what should be our guideline? Low disease activity, hydroxychloroquine, first choice, sulfasalazine should be preferred over methotrexate, and methotrexate should be preferred over leflunomide. Mind you, this is a state of low disease activity. When the disease activity is moderate or high, then DMARD monotherapy can be done. Prefer methotrexate here first over hydroxychloroquine and sulfasalazine, biological DMARD and targeted synthetic DMARD next, or methotrexate plus non-TNF inhibitor biological DMARD should be preferred, or alternatively targeted synthetic DMARD. So this is the whole crux of therapy in cases of moderate and high disease activity. Monotherapy or combination therapy, ultimately leading finally to use of targeted synthetic. Now there are patients who are not responding and still the disease is moderate or severe. So then go for conventional combination, conventional synthetic DMARD. Go for not mono, but dual therapy or triple therapy. Targeted synthetic, if you have to use, either use monotherapy, but preferably always with methotrexate. Leflunomide can also be added. Alternatively, TNF alpha inhibitor with or without methotrexate, and alternatively non-TNF inhibitor with or without methotrexate. Now, the methotrexate naive patient, but conventional synthetic DMARD treated. So all the other conventional synthetic DMARD have been used, but methotrexate has not been used. So moderate to high disease activity, prefer methotrexate over combination with biologic. Over combination with biologic DMARDs or TS DMARDs. So what are the rules for use of glucocorticoid? This will be an additional drug. So if the patient has been on initial CS-DMARD therapy, prefer not to use glucocorticoid, but can be used on initiating or changing the CS-DMARD. Initial short-term, less than 3-month glucocorticoid for RA disease flares, and consider using short-term glucocorticoid. Long-term glucocorticoid, if for more than 3 months, moderate or high RA disease activity, DMARD failure cases, or biologic failure cases. So these are delineated areas where glucocorticoids must be used. Now, the addendum to the treatment is that to provide best benefit risk ratio for the patient, use glucocorticoids, but lowest possible dose for shortest possible duration. Risk of long-term glucocorticoid therapy must be evaluated. Use acceptable glucocorticoid dose. Risk of harm generally low at long-term dose of less than 5 milligram prednisolone. Taper glucocorticoid as rapidly as clinically feasible. Now, go low, go slow must be used in cases of early use of DMARDs. So from pyramidal approach of DMARD monotherapy to step up combination therapy, treatment targeted tight strategy, or early step down with combination therapy, which goes by the name of inverse pyramid approach. So talking about spondyloarthropathy, we have formed guidelines. We will not go into this. What is the first line of therapy in spondyloarthropathy? Continuous 2 NSAID for 4 weeks, each 1 week plus the other one 3 weeks, or 2 weeks, 2 weeks each. So 2 NSAIDs for minimum 4 weeks. No preferred NSAIDs are there. No systemic glucocorticoid should be used, and peripheral arthritis, use sulfasalazine or methotrexate. First line therapy, local glucocorticoid infiltration. If 2 or less than 2 peripheral joints are involved, or isolated sacroiliitis also, you can give local glucocorticoid infiltration. Avoid enthesitis areas like patellar, Achilles, and quadriceps tendon. Well, physiotherapy and active exercises, they form basic treatment in spondyloarthropathy. This was first line. Now the second line, first choice is TNF-alpha inhibitors. No preferred TNF-alpha, whatever you like. Second choice is secukinumab or ixazumab. Third choice is tofacitinib. And for ankylosing spondylitis with interstitial bowel disease or uveitis, prefer monoclonal antibodies. So adalimumab, infliximab, golimumab, etc. are choices. Here etanercept is not the choice. So uveitis, etanercept is not the choice. The management is stop, look, and go. So reassess the patient. And now I will shift to, well, this I always like to say that traditional DMARDs, can they be used in ankylosing spondylitis or spondyloarthropathy? There are recommendations using traditional DMARDs de novo in higher doses or following biological therapy whenever cost is a constraint. And I say sulfasalazine, even otherwise, has potent anti-inflammatory effect similar to and also antibacterial and immunomodulator. In psoriatic arthritis, higher dosage of methotrexate are more effective, and results are compared to rheumatoid arthritis, and remission is achievable in 20%. Now, after this talk, I would like to request Dr. Madan J. Raman, who is waiting from the very beginning, for a very important talk that we have been discussing about orthobiologics. So he will be discussing about immunological crosstalks between mesenchymal stem cells and rheumatology considerations. Dr. Madan, your term. I'm stopping sharing. Right.
I'm sharing my screen, sir.
Yes, sure. You have to finish within 7-8 minutes.
Yes, sir. Yes, sir. It's just 20 slides.
Right.
Very good evening. Myself, Dr. Madan Jayaraman from Lalitambir Medical College, Chennai. I'll be dealing with immunological crosstalks between mesenchymal stromal cells and rheumatology, especially with rheumatoid arthritis I'm dealing with. So the basis of orthobiologics is nothing but the three things should be working in together. That is matrix materials, which is the ground substance that is called scaffolds. The second one is the growth factors. These growth factors induce the locally available stem cells to direct towards the desired action. And last one is the stem cell. So all three things should be there in particular area to induce the tissue engineering process. That is tissue reparative process. So there are various sources of mesenchymal stromal cells. As orthopedic surgeon, we are very well versed with bone marrow, which contains mesenchymal stromal cells. Now, recent ideology is on adipose tissue and synovium. As well, other things are all there: embryonic tissue, placenta, endometrium, and peripheral blood. Embryonic tissue, it is not being used for routine therapeutic purpose. It is only for research, and it has a disadvantage of cloning. So it has been banned for therapeutic purposes. Umbilical cord and placenta amniotic fluid, all these contains, including water and jelly, will contain totipotent stem cells, as well as endometrium contains pluripotent stem cells. What is peripheral blood? Peripheral blood contains stem cells. How? We have to mobilize the progenitor from the bone marrow. So by giving granulocyte monocyte colony stimulating factor, if we give CSF 200 micrograms subcutaneous dose for 3 days, your progenitors will come to the periphery. From peripheral blood, we can take peripheral blood and go for cellular counting and identification. We can find MSCs. So these are the overall view of sources for MSCs. That is mesenchymal stromal cells. So every mesenchymal stromal cell, whatever we are giving, it should not get rejected. Either it is autologous or allogenic. But MSCs are not getting rejected because there is immunomodulatory capacity of that mesenchymal stromal cells. These mesenchymal stromal cells are nothing but undifferentiated blank cell which doesn't have any CD4 marker or any other markers which give cross reaction to body's own self. That's why we are using immunomodulated MSCs in autoimmune diseases. So the basis of autoimmune diseases is nothing but autoantibodies are killing the body's own cell. So that's why we are getting autoimmune diseases. Here MSC has immunomodulation capacity by 2-3 mechanisms are acting here. So I'll be explaining the mechanisms. So as a mesenchymal stromal cell, it will secrete nitric oxide. So this nitric oxide will stimulate CD8 cell, that is called a killer cell, which will activate, in routine, it will activate CD8 plus cells. So, but this MSCs will inhibit the action of CD8 plus cells. And the second one is this MSCs will inhibit the action of B cells. This B cells will secrete plasma cells and interferons. So it will act 2 pathways. The third pathway is it will inhibit CD4 plus also. So that your CD4 activated cells, whichever is present in the blood, it will regulate only T helper 2 cells and T regulator cells, because the end product of T helper 2 cells is IL4. This IL4 is an anti-inflammatory molecule, and TGF, the end product of T regulatory cells are TGF beta, that is increased transforming growth factor beta, which is a chondrocytic in nature, and even it helps in stimulating the other progenitors as well. The second mechanism of immunomodulation of MSCs are through HLA-G5. This is a soluble antigen, HLA-G5. It will act via this and immunodioxygenase system along with the help of prostaglandins E2. So all these things act in the MSC. So it will inhibit NK cell, T cell action. So all the action, even dendritic cell action, every action is suspended. So your autoantibodies will get destroyed and we can go for regeneration of that particular tissue or anti-inflammatory effect of that particular disease. So now come to knee joint proper. If it is a rheumatoid knee, for example, consider this as a rheumatoid knee. So all anti-inflammatory proteins will be there, inflammatory proteins will be there. Both will be mismatching. Disequilibrium will be there. So inflammatory proteins will be more outweighing the anti-inflammatory proteins. Along with there will be tissue degradation products that is called damp molecules. All these molecules present in the synovium, synovial fluid, and along with the bone lining also. So these things causes when a patient has rheumatoid arthritis, so these things will be there more in the joint. So the joint will go for degeneration, secondary OA. So anti-inflammatory proteins are very less. So this is the basic pathology of arthritis. So what MSC will do when we are putting MSCs here, for example, this place, if we are putting MSCs into the knee joint, what MSC will do? What all cells will act with MSC? First one is B cell. Already I have told B cell proliferation will be inhibited. And so your plasma cell won't get converted. Immunoglobulins, interferons, nothing will be released. So it will inhibit B cell. The second one is it activates T2 cells, that is T helper 2 cells, and T17 cells, that is T regulatory cells. Only these two will get activated. So what all will be inhibited? T cell apoptosis will be inhibited, and other these TH17 and T regulatory cells will be activated. So T cell proliferation may happen, and it will give anti-inflammatory effect via interleukin 4 and TGF beta. The third one, the main important culprit in all the diseases is macrophage. This macrophage we have to get converted into, that is called macrophage polarization. So M1 macrophage, which is present in the joint, will be pro-inflammatory. So always the pro-inflammatory has to be converted into anti-inflammatory molecule. That's why macrophage polarization will be happening. These macrophages are obtained from monocyte lineage. So this monocyte will get converted into M1 macrophage. This M1 macrophage will increase the pro-inflammatory cascade. So when you put one MSC inside, that MSC will convert monocyte into M2 macrophage, that M2A, 2B, 2C. So many subsections are there, but M2 macrophage is a better macrophage which has anti-inflammatory cascade. Third one is NK cell. So MSCs inhibit NK cell via that HLA-G5, which we saw earlier. So in turn, it inhibits DC, that is called dendritic cells, which further inhibits T cells. So all these cells act one in one. It will act simultaneously to inhibit the other, so that your anti-inflammation property will be upraised and pro-inflammatory will get downregulated. So whenever there is a tissue injury, for example, if you take rheumatoid arthritis, so consider this tissue injury as a rheumatoid arthritis. Now the consensus have come, gut microbiome, that is called gut dysbiosis, causes rheumatoid arthritis. Mainly to tell, Porphyromonas gingivalis is the main culprit, and Prevotella is the main. These two are the main culprits which causes rheumatoid arthritis. This has been the consensus being given. So consider microbial pathogens enters the tissue and it starts autoinflammation. So once if you put MSCs, it will be releasing a lot of cytokines and chemokines. This macrophage that is derived from monocytes, this converted into M1 macrophage, which will be pro-inflammatory. So all inflammatory molecules will be increased. That is, phagocytes, ability of the neutrophils, macrophages will get increased. Cytotoxicity of NK cells, T cells, everything will get increased. Even B cells will increase and immunoglobulins will be produced. Once, if you put MSC in the phase of tissue repair during the second week or third week after the inflammation subsides, when we put MSCs into it, what happens? This MSCs will get convert that monocyte into macrophage 2, so that anti-inflammation will happen. See, finally anti-inflammation happens. Then it will inhibit dendritic cell and it will upregulate T regulatory cells. So regulation of T cells will be happening along with the synthesis of TGF beta That is very important molecule in terms of regeneration. So what in overall in tissue repair, what will happen? There is upregulation of anti-inflammatory molecules, down-regulation of pro-inflammatory molecules. It's a very simple funda. So what MSC actually does in rheumatoid arthritis? That's what we saw. Immunomodulation, anti-inflammatory, less immunogenic, pluripotency. It is a pluripotent cell and it will enhance in tissue regeneration. So everything I have explained here, the only one thing which I haven't explained is secretomes. What is this secretome? This is very important concept nowadays. Secretomes and exosomes. In the whole body, we have from top to bottom, like from hair to nail, toenail, we have exosomes and secretomes. But these exosomes and secretomes from MSCs, that is called mesenchymal stromal cell derived exosome or secretome, which will have very good regenerative capacity, which will bypass all the pro-inflammatory molecules and it will give direct target site of action and it will reduces the inflammation immediately. So overall, we have seen all these cells. NK cell, I have told B cell, T cell, macrophage, and dendritic cell. What are these three things? Chondrocyte, mast cell, and complements. So these MSCs will reduce complement activation so that it will not trigger the further immune responses. This mast cell also, it will be degranulator. Else, what will happen if mast cell is getting increased in plasma and blood? There will be increase in IgE antibodies, which will be an allergic one. And what happens in chondrocyte, especially in chondrocyte, what will happen? So whatever degeneration happens, there will be no collagen, no water, no GAGs. GAGs are nothing but glucosaminoglycans. So when you put one MSC into chondrocyte, what will happen? It will increase the synthesis of collagen. First one is collagen. The type 2 collagen, very specific type 2 collagen will be increased. Then aggrecan, proteogen, everything will be synthesized to form an extracellular matrix. That is the second one. What all will get down-regulated? It will suppress apoptosis, senescence, and it will down-regulate the pro-inflammatory cytokines. That is IL-1, IL-6, chemokines 2 and 5. So all these things will get down-regulated. So these are all the overall immunological cross-talks of MSCs in response to rheumatology. Rheumatology itself, it's a big terminology, but all the cells act in the same way because all are autoimmune diseases. Now come to a comparison, just a comparison between OA and RA. In OA knee, we will get degenerated knee. Here also the degeneration will be in RA, we will get degeneration along with synovial hypertrophy, that is called PANS. So once we give MSCs into the knee joint of OA or RA, first let us see OA. OA will be joint regeneration will happen. Immediately there will be no cartilage. So specks of cartilage growth will be seen. So how will we inject? We will inject only intra-articularly. And what we can expect in OA is immediate pain reduction and slow recovery of damaged cartilage. That is, a cartilage will get regenerated. Now come to RA. What is the treatment purpose? RA is autoimmune diseases. So your inflammation will come down. Suddenly your inflammation will come down, which can be checked by ESR, CRP, procalcitonin, and other markers, RA, everything. Serum RA factor, anti-CCP, everything we can check to control whether the inflammation has been controlled or not. How will we give? We can give two things. One is intra-articular and second one is intravenous. Everyone will tell already peripheral blood stem cells, if we take, the stem cells are there in the body. Yes, it is there in the body, but it is not doing the proper work because it was not in the concentrated way and it is not directly towards the target site. Once we isolate your stem cells and give to the proper channel, it will reach the target site. At least if we give 1 million cells, at least half of the dose will get reach the target site to initiate the action. So here in rheumatoid, not alone rheumatoid, in all systemic diseases, it's better to give IV stem cells along with the local stem cells. Local stem cells meaning in the local area. If knee joint is involved, give 1 dose in the knee joint as well, because your hypertrophy, PANS hypertrophy, synovial hypertrophy, PANS cicatrization, everything will come down along with your inflammation also will come down. But is there any evidence for this? Yes, there are very little evidences for rheumatoid arthritis. There are a lot of consensus for OA, but not for RA. Still, a lot of studies have to come up. Since the patient is being autoimmune, that is what called autoantibodies are there. Mild immunological response will be there in terms of pain, swelling, some pruritus, itching, all those things will be there in RA. So how to improve the quality of MSCs being given to RA? I mean rheumatology. Either you have to induce MSCs with hypoxic condition. If you keep under hypoxia, MSCs will have better regenerative quality. These cytokines are nothing but small molecules which Jasser has told, that is cytokines, chemokines, all the small molecules which is anti-inflammatory and protrophic effect, that is called regenerative effect. And co-culturing is nothing but inducing the genes. Now everything has come. The 3D culturing, that is 3D printing along with 3D culturing has come, and genetic modification, autophagy. All these things, all these 6 modalities will increase the regenerative capacity of MSCs when given to RA. So what are the pros and cons between giving intravenous therapy of MSCs to autoimmune patients? It will have better immunomodulation, as I have told from starting. It will have better immunomodulation. The second thing will be, it is very safe. If you take an autologous blood, it is very safe. It is non-immunogenic, non-tumorigenic, no toxicity. Again, people may argue it is auto antibodies are found in blood. Yes, it is found in blood, but it won't get bound to your MSCs. MSCs doesn't have any cell surface receptors, and it is very safe and effective. Effective in terms of, whenever you are giving any MSC, it will go and give paracrine action. It will go and settle in one place and start spreading your cytokines, that is biomicromolecules, that is called small molecules. What are all the disadvantages? First one is source. Which source we have to see? Either bone marrow, peripheral blood, umbilical cord. If you are using umbilical cord, amniotic fluid, or all allogenic part, you have allogenic. Already these people are autoimmune diseased patients, so allogenic MSCs may have some more add-on effect. So better to avoid allogenic part. Then autologous. If autologous, what are all the sources? I have listed out so many sources. So from which source you will get a better result? That is a concern. And whenever you are giving an IV, it will go to the pulmonary circulation and will get trapped in the lung and it will be thrown out. So that is the second one. Third one is since it is an systemic involvement, we are giving systematically into the intravenous route. We have to find out what is the dose, what is the frequency. That is not matching. And moreover, it is a systemic disease. Multiple short-term doses we have to give for top-up. And finally, production cost. If we are going for autologous, there won't be much production cost. But if your autologous cells are not sufficient enough to meet the desired state, then we have to culture expand the cells. And culture needs a certified GMP lab. So all these things are disadvantages of using MSCs in any diseases, not alone rheumatoid, any disease concern. So my take-home message is, MSCs, if you use in rheumatology or anywhere, it has immunomodulatory effect, immunoprivileged cells, non-tumorigenic, non-toxic cells, and it will have paracrine effects. Multiple dosing is needed for a short, because it is short-acting, multiple dosing may be needed. Autologous culture needs GMP labs, and allogenic is still a question. And section 351, 361 talks about the regulatory guidelines and frameworks of MSCs to be used in research or therapeutic purposes. Thank you.
Thank you, Dr. Madan. You have rightly said that immunomodulation is the key. And many times we prefer calling it immunosuppression, but the exact word that we should use is immunomodulation. And you have discussed all the immunomodulator cells in relevance to this parallelism between MSC and all the other kind of management which is desirable in cases of rheumatoid arthritis. So one last question that I can pose to you: do you think that MSCs, particularly its use in rheumatoid arthritis, is going to be very practical?
No, sir, it won't be practical because it needs multiple dosing. Patient won't be affordable, and it is a long-term treatment. It's not like OA. OA 1 or 2 doses will be sufficient to meet the needs to reduce the pain. But in case of RA, we need to give multiple dosing, which adds a big burden to the patient. Practically, it is not possible, sir. But as well, we can go for further research to add scaffold or something so that it will be there in the blood for longer time and it will elute the MSC molecules. I mean, small molecules from MSCs.
It was a very good presentation. Well, we have
Dr. Madan, one question.
Overshot the time. Yes, please.
Dr. Madan, are you using these MSCs or are they being used in OA?
The OA we are using, sir. OA
Yes.
in the form of BMAC, SVF, everything we are using.
So
sir.
what is the from where you are harvesting them actually?
Bone marrow we are harvesting from ASIS or PSIS, sir.
Okay, so basically the bone marrow is the source. No
Sir,
other
for
source.
cartilage regeneration, other than bone marrow, adipose gives the better cartilage regenerate than bone marrow, sir.
Yes, Dr. Amarnath also wanted to highlight something. Please highlight.
Sure.
Yeah, I think the answering the question, I think, Madan, thank you. Basically, today we have, it's 8 weeks now in India. We have the off-the-shelf autologous, bone marrow mesenchymal cells, which is available now, which has been certified, which has been, I have given it to 3 patients in Bengaluru, and all over India, 33 patients, I think, or 33 or 34 patients have received in the last 7 weeks. This therapy is available in osteoarthritis.
Now
and
the figure has crossed 50. Yes.
Fantastic.
Right.
Because I have
You were the
98-year-old man waiting for the insurance approval. Hopefully,
you
post
were the first
Pongal, I think Sankranti.
Right.
Is it commercially available?
Yes, it is commercially available
7 weeks
by
ago.
the name of STEM 1.
STEM 1.
Yes, sir.
The cost is 1.20.
25. Yes, sir.
2025, but it can be made available to you in 1 lakh only.
Okay, sir. And how many dosages are you prescribing, sir?
Only one.
One dose.
Single dose. Okay, sir. Thank you very much.
Okay. So, Dr. Dilip, you are there. He's traveling in a train and he had said he may get disconnected. And I think Dr. Keskar also has not been able to join because he was to travel from his office to his home. And maybe there was a lot of traffic jam. Even otherwise, we have overshot. So we leave aside the discussion part. And I'm very sure I will keep half an hour next part of biological discussion for questions alone. Now, I would request Dr. Sarath, who is waiting for vote of thanks. Sarath, first of all, let me welcome you. This is your maiden appearance in this
Thank you, sir.
first webinar, and you are a very esteemed member of this subcommittee.
Thank you, sir.
Sincerely hope from next time you also start making presentations.
Sure, sir. Thank you, sir, for your nice words, sir. Good evening, everyone.
Before your vote of thanks, Dr. Chinmoy, you wanted to say something.
No, sir. I just want to thank you. Nothing I want to say.
Okay, please go ahead.
Okay, sir. Good evening, everyone. I am like a sapling in this giant trees of orthopedic rheumatology. I have been given this responsibility. So I am Dr. Sharath Agrawal, Professor Orthopedics, and in charge of pediatric orthopedics at NIGRIMS, which is a AIIMS-like autonomous tertiary central institute under Government of India as a referral center for the northeastern region of the country. And now a proud member of course, Biological Ortho Rheumatology Group of IOA and a Rheumatology Subcommittee of IOA 2023. I take this opportunity to thank each and everyone who made this webinar on orthopedic rheumatology possible, thereby achieving the purpose of disseminating knowledge and constantly upgrading through such continuous academic interactions. I would first like to express my gratitude to Dr. Atul Srivastava, Honorable President IOA, for his valuable time and for his inspiring words, which will motivate each one of us to continue these academic sessions in times to come. To add, my association with him is around 35 years old, and I express my heartfelt gratitude to him. I would also like to thank Dr. Ram Chaddha, the President-elect of IOA. My sincere thanks goes to Dr. Naveen Thakkar, the Secretary General IOA, whose presence and words have been the source of encouragement for us. Dr. Shantanu, Lahkar, President IORA, is a guiding light to plan such sessions. So we thank you, sir, for your supervision and guidance. We are thankful to our gracious speakers today for their hard work in preparing and presenting this enlightening talk on various aspects of orthobiologics and recent advances in the field of orthopedic rheumatology, which is all new for all of us in orthopedics. My heartfelt thanks goes to Dr. Ranjeet Singh from Patna, with whom I got the opportunity to meet at IOCON in Jaipur, sir, which was held at 2 years back. My sincere thanks goes to Dr. P. Dhansekhra Raja Coimbatore, Dr. Chinmoy Das Dispur, Dr. A. Rajamani, Madurai, Dr. Ravi Gupta Chandigarh, Dr. Madan Jayaraman Chennai, Dr. Dilip Mazumdar, and of course, Dr. Sanjay Keshkar and Dr. from Calcutta and Dr. Manish Khanna from Lucknow in absentia. And of course, I would like to specially thank Dr. S.S. Jha sir, who has been the founding father of IORA and has spearheaded in coordinating and initiating this unique webinar series. Of course, I remember you, sir, when I was the Secretary Orthopedic Society Shillong, and you came to the Shillong, which is the Scotland of East, in annual conference of Indian Orthopaedic Rheumatology Association as president, almost a decade back, sir. Thank you for your invitation, sir, and your nice words for me again. We are obliged to Dr. Ashok Shyam, Dr. Neeraj Bijlani, Dr. Shamsal Huda for giving us this platform for this unique academic extravaganza. Last but not the least, I express my sincere gratitude to all delegates who attended this session and made our efforts worthwhile. I hope to see you all in our next session. And with this, I wrap up my vote of thanks. Thank you all once again. Thank you.
Thank you very much. I would only like to add Dr. S.S. Amarnath only on a day's notice. I talked to him only yesterday and he became ready.
Okay, yeah, so sorry, sir, for
made a
that.
very good presentation.
Sorry,
Right.
my apologies.
He was out of list. Out of syllabus. So he was out of syllabus. Right. But the syllabus could not have completed without you. Amarnath, thank you once again. So thank you, everybody. All the wives must be angry. We are too late.
Yes.
Right. So kindly say thanks to all the wives also who are waiting in the kitchen. Thank you.
Thank you to all of them, or too from my side also. Thank you.
Right.
Thank you, sir. Good
Bye.
night.
Thank you, sir. Thank you.
Thank you, sir.
Thank you,
Thank
and
you,
good night,
everybody.
sir.
Bye.
Good night, everybody.
Yes,
Good
if
night.
there is anybody in this studio, so thank you very much. We can close now. So what we can do is we will leave. I think.
Okay, sir. Thank you.
Right. Okay, bye. Mr. President, any last word? Lahkar chala gaya. Okay. ठीक रंजीत.
Okay, sir. Good night, sir.
Good night.
ठीक ही रहा, sir.
हाँ नहीं बढ़िया आपका प्रेजेंटेशन भी हुआ. चलिए.
ठीक है, sir.
अभी बंद हो गया.
फिर बात करता हूँ, sir, कल.
हाँ.
Okay, sir. Good night.
स्टॉप शेयर में है. ओके. इसीलिए नहीं बंद हो रहा है. लाइव तो थे. लीव. यस, देयर इज a leave option. Leave the